Good morning to everyone. So, one of the topics for discussion from my side is on hypercalcemia. So, I'll be discussing about the introduction, etiology, clinical manifestation, and management. So, coming to the introduction, hypercalcemia is a rare in critically ill patients, and it's estimated to be present in 1 to 15% of ICU patients. So it is defined as an increase in the serum calcium more than 10.5 milligrams per deciliter. And the most common etiologies are attributed to primary hyperparathyroidism, hypercalcemia, malignancy. These two etiologies alone contribute to 90% of the cases. So coming to the etiology, it can be because of excessive parathormone production, which can be attributed to primary hyperparathyroidism, which can be because of an adenoma or a hyperplasia, or it can be because of a tertiary hyperparathyroidism, where there is a long-term stimulation of parathormone secretion in CPD, or there can be alteration in the calcium sensor receptor function, that is CSR, that is associated with lithium therapy. Or it can be associated with hypercalcemia of malignancy, where there can be an overproduction of parathormone-related peptide, as seen in many solid tumors, or there can be lytic skeletal metastasis, as in breast cancer or myeloma. Or in conditions where there is excessive 1,25 dihydroxyvitamin D production, like in granulomatous diseases like tuberculosis, sarcoidosis, or silicosis, lymphomas, or vitamin D intoxication. In conditions where there is primary increase in bone resorption like hyperthyroidism and immobilization, excessive calcium intake like in milk alkali syndrome or total parenteral nutrition, medications like thiazides, vitamin A, or antihistamines, and endocrine etiologies like pheochromocytoma or adrenal insufficiency. So in these scenarios, hypercalcemia is likely to occur. So the clinical manifestations, they become evident when the serum calcium is more than 12 milligrams per deciliter, or the ionized calcium that can be seen in the VBG reports is more than 3 millimoles per liter. So um, the most common clinical manifestation occurs mainly because of alteration of the charge balance across the cell membrane. So, as you know, for an action potential to occur, there should be a gradient between the extracellular and the intracellular charges. That is, the positive and negative ion should be in a gradient fashion for an effective depolarization to occur. So, when there is hypercalcemia, there is an increase in the positive charges outside the cell, so that interferes with the action potential. So, that can decrease the rate of action potential, causing a decrease in the depolarization. So, sodium channels on the neuronal membranes become more resistant to opening. That is, they resist sodium influx. So, that causes a decrease in the neuronal action potential generation, leading to sluggish neuronal activity. So, it can manifest as a either cognitive dysfunction, confusion, stupor, or in worst case scenario, they can go into even coma. And from a neuromuscular junction perspective, they can present with fatigue or generalized weakness. With respect to the gastrointestinal system, because of the decrease in action potential and depolarization, there will be a decrease in the transit of the gut activity. So that can lead to constipation. And because of constipation and decreased motility, there can be a decrease in the appetite. So the next thing is calcium precipitates with phosphate throughout the body, and the most important site is in the urinary tract, where it has high predisposition to form renal stones that can manifest as flank pain. And calcium can directly inhibit the insertion of aquaporin channels in the collecting duct membrane. So aquaporin is nothing but the antidiuretic hormone site of action. So because of that, there will be less reabsorption of water that occurs. And because of that, there will be increased water excretion and that can lead to dehydration. So with regard to the management, well, as I previously told, we have two aspects, the diagnosis and treatment. So both need to be mentioned. So with regard to the diagnostic evaluation, the most important thing is the history. So usually with history itself, if it is detailedly taken, you will be able to identify clues towards the cause of hypercalcemia. So it is important to look into the family history, drugs, and history of malignancy. Next is the diagnostic approach with regard to the tests that need to be done. The first important test is the serum parathormone levels. If it is elevated, then it goes in favor of a primary hyperparathyroidism. And like I said, it can be either because of an adenoma or a hyperplasia. Whereas if it is normal or low, you need to look for other causes. And in the history, if nothing is very much apparent, then you need to look into the parathormone related peptide 1 comma 25 dihydroxy vitamin D levels and the 25 hydroxy vitamin D levels. So if the parathormone related peptide level is elevated, then it goes into hypercalcemia of malignancy as the most likely diagnosis. But if it is negative, then you need to check into the 1 comma 25 dihydroxy vitamin D levels. If that is elevated, then granulomatous diseases is like high probability. That is TB, sarcoidosis, silicosis, or lymphomas. Whereas if that is negative, you need to just check 25 hydroxy vitamin D levels if it is increased. If it is increased, then vitamin D intoxication is a high likely diagnosis to be considered. Whereas if that is also normal, then you need to check for serum protein electrophoresis and serum light chain assay. If that is elevated, then goes more in favor of a myeloma. Whereas if that is also normal, then you need to look for other causes like hyperthyroidism or adrenal insufficiency or pheochromocytomas. But all that is in a clinical context. So one thing I would like to emphasize is usually when you read about hypercalcemia, there is always a confusion about what is the likely diagnosis if 1 comma 25 dihydroxy vitamin D is elevated or just 25 hydroxy vitamin D is elevated. The easiest way to remember is since there is only a single number, we have only a single diagnosis. So since it is 25 hydroxy vitamin D, it is only likely to be vitamin D intoxication. But here there are two numbers, 1 comma 25. So it can be either granulomatous disease or lymphoma. So this is one of the easiest way to remember it before the exams. So coming to the treatment, it can be classified based on the severity. In mild and moderate cases, that is mild where the calcium is between 10.5 to 12, and moderate where it is between 12 to 14, it does not require immediate treatment because the patients may not be very symptomatic. Because the most symptomatic issues that we are going to look into the central nervous system related issues, which are more concerning. So those features are not predominantly there. We don't need to go very aggressive in the treatment. However, adequate hydration is recommended because, like I said, hypercalcemia will induce dehydration and that can cause various complications. And in addition to that, you need to avoid any other precipitating factors like thiazide intake, lithium, volume depletion, and if calcium supplements are being administered, that needs to be stopped. Whereas if it is severe hypercalcemia that is more than 14 milligrams per deciliter, we have various treatment modalities. Number one in the list is isotonic saline. So the dosing they say is to go with 200 to 500 ml per hour to maintain an output of 100 to 150 ml per hour. Now, this is from a textbook perspective, but in real practice, you can go with focus-based assessment and decide on the fluid administration. Okay. So the goal is to promote renal excretion of calcium. So the rationale is hypercalcemia usually is accompanied by hypercalciuria, which produces an osmotic diuretic effect, and that leads to hypovolemia. So because of that, there is a decreased excretion of calcium in urine, and that precipitates a rapid rise of serum calcium. I'll repeat it once more. Hypercalcemia usually is accompanied by hypercalciuria. Hypercalciuria produces an osmotic diuresis, which leads to hypovolemia. Now, because of this hypovolemia, there is going to be a decrease in excretion of calcium in urine, and that precipitates a rapid rise in the serum calcium levels. So, the only concern is in patients who have volume overload states, that is already pre-existing heart failure, or they have developed an AKA, or already have a CKD status where they are in oliguric status, you need to be very careful with regard to the use of fluids. And you also need to consider the use of loop diuretics in these scenarios. These are one of the few situations where you can go ahead with IV fluids on one side and diuretics on the other side to maintain a adequate volume status, preventing volume overload. The next treatment modality is a loop diuretic, furosemide, which is the most commonly used. And the dosing recommendation that is said is to go with 40 to 80 milligrams every 12th hour to maintain a urine output of 100 to 150 ml per hour. So the main rationale for this is saline infusion alone does not correct hypercalcemia in 70% of the patients. Often, furosemide is needed to promote further urinary excretion of calcium. But however, it is important to note it promotes hypovolemia, hence it is only recommended in cases of patients with volume overload. The next drug is calcitonin. The dosing goes by 4 units per kg and it is given 12 hourly for a duration of 24 to 48 hours. So, in one day, if the response is not satisfactory, then you can increase it to 8 units per kg every 6 to 8 hours. So, it acts by inhibiting bone resorption plus increasing renal calcium excretion, and it is associated with tachyphylaxis. So, usually, more than 48 hours, calcitonin is generally not given because more than that period, it is not going to be effective. The next important drug is glucocorticoids. So the dosing goes with 200 to 400 milligrams per day for 3 to 5 days. So its mechanism of action is it acts by increasing the renal excretion of calcium, decreasing the osteoclast activity in bone, and decreasing extrarenal production of calcitriol in lymphoma and myeloma. But in patients who have an hypercalcemia of malignancy, especially associated with the lymphomas and leukemias, you need to be very, very cautious with regard to the use of hydrocortisone or any steroids for that matter, because if they are going to be a sensitive tumor to steroids, that is going to have a high chance of precipitating a tumor lysis syndrome, which is going to be a bigger headache to deal with. The next drug is about bisphosphonates. We can either go with zoledronic acid or palmitonate. With regard to zoledronic acid, it is given at a dose of 4 to 8 milligrams IV over 15 minutes, whereas for palmitonate, it is 90 milligrams IV over 2 hours. Both drugs are given as a single dose alone. You don't need to have any repeated dose. The onset of action comes within 1 to 3 days, and the duration occurs for 2 to 4 weeks. So it has main activity only in relation to the bone, where it inhibits bone resorption via interference with osteoclast recruitment and function. So it prevents bone resorption. Then we have denosumab, which is a monoclonal antibody, which is used in cases where bisphosphonates are contraindicated or refractory hypercalcemia is present. And it is given as a dose of 120 milligrams once weekly subcutaneously. So the mechanism of activity is it inhibits bone resorption via inhibition of the Rankel receptor, that is receptor activator of nuclear factor kappa beta ligand. And in worst case scenario, where calcium levels are in the range of 18 to 20, sorry, it's not 80 to 20, it is 18 to 20 milligrams per deciliter, dialysis should be considered. Thank you.